Bonjour, bienvenue au deuxième Zebinaire de notre mois de Zébrier au regroupement québécois des maladies.
Welcome to our second Zebra webinar for our organization and for our month. And is it possible to see my slides, the overhead, and can I share them? Do you see my slides? The odyssey of those without a diagnosis is our topic. During the Zebra month, we have Zebra webinars for all of our activities. And so our goal is to talk about diagnosis, wanderings, and so on, because a lot of people live with rare diseases, illnesses that are never considered for a diagnosis. They never get a diagnosis per se. Our mission, we have a center and we manage it. It's called the IRE Centre, IRE. It's an information center. It's supporting rare diseases and so on. Even if you don't have a diagnosis, get in touch with us and we can give you some guidelines. We share information about rare disease and their issues, challenges, research, medications are entertained. During the Zebra month and during the year also, we try to raise the awareness of the public regarding orphan disease, rare disease, and we foster research by making sure that personal supporting people, researchers, and orphan disease people with orphan disease can meet together, or rare disease. And we discuss with the government in order to make sure that we have a strategy plan at a political level for rare disease in Quebec. And I can tell you that things are progressing, and we're going to work on several folders. Neonatal screening, we're going to hear about today. A few statistics. To use a statistic which is current, 6 to 8% of people within a population would be impacted by a rare disease. For us, this would be about 700,000 people. And normally, this impacts the life of many children. 500 children would be impacted. At this current stage, at this time, 40 to 50% of people don't have a diagnosis. They're without any diagnosis. We had a survey for our foundation in 2010. This is a survey at the RQMO. 37% of respondents told us that it took them 3 years or more to obtain a diagnosis. 8%, it took them more than 10 years. 30% of them had consulted with 5 doctors or more before getting their diagnosis. So has this changed or not since then? We'd have to conduct a survey again, but many surveys were conducted since then. Board Canadian Organization for Rare Disorders, they did the same thing. They had a similar survey in 2015. The AMR in Europe, in France also, they have about the same statistics at Eurordis. 7-8 years, that's the average the time that it takes you to get a diagnosis as an average. We can break down these 100 diagnoses in several categories. Those that don't have a diagnosis are people who are being they are undergoing tests currently in order to discover if they can get a diagnosis or not. This may take some time, obviously, and they would eventually reach a level when they would get a diagnosis. So there are 3 categories. Those that don't have their diagnosis yet. There are the people that don't have a diagnosis. And now we know that there's a lot of psychosomatic diseases that have not been characterized. Diseases sometimes are not characterized, especially with gene disease. We will use sequencing now, new technologies. Our guest today will tell you more about it. for neonatal screening. And regarding research also on that base, we can find new things. Sometimes we have new genes. Sometimes we have known genes which are linked with a disease that's different. We are making progress on that front at the genetic level. We'll have presentations in February on that. So after the people without any diagnosis, as I said, we have psychosomatic diagnoses, which means that you have non-specific symptoms, a whole set of symptoms. This may vary from one time to another throughout time. And so this doesn't show physically. There are no physical signs of the disease. It's mainly women who are impacted here. Unfortunately, we don't find anything through tests. It's non-positive, it's negative, and there's an outcome where they say these people are psychosomatic, somatophobia people. It's very hard to obtain a real diagnosis after that initial diagnosis. And so in some cases, you have real rare diseases, but some are not don't have a diagnosis for a rare disease yet. So these categories and now consequences, all the surveys indicate around the world cases where when there's no diagnosis, there are false diagnoses, false positives, or errors in the treatments, and it's hard to treat people. It's out of a trial and error that you can deal with those things. Surgery or sometimes the drug use is not appropriate. It's hard to come up with a real solution when you don't have the details. Psychosocially, this has a lot of impact. There's a lot of uncertainty during the whole diagnosis quest. It's hard to find services, to have access to services when you don't have a precise diagnosis name. You fall through the cracks of the different categories. You don't have access to the different governmental services. There's psychological despair, lack of trust in the health system also. As a result, doctors cannot learn from all the rare diseases, between 7 and 8,000 every week. New discoveries occur with a new gene-based techniques. So new diseases are born every week. So we can't ask doctors to know about all these diseases, but they could get some training. Doctors could be trained about an approach, the right approach vis-a-vis those patients with those rare diseases, because this is not a common thing. In France, there's the National Plan for Rare Diseases. The doubt-based culture was advocated then for doctors. You can think outside of a box with a doubt, which means with curiosity. Instead of abandoning, you have to be curious, think outside of the box, and then believe in the patient when they are describing symptoms. So you need resources also. In Quebec, there's work done by the Department of Health and Social Services in order to adopt a national strategy. That's what we ask for, that we get or we provide some medical training with the curiosity or doubt culture as in France. But doctors need to have the right resources. They have to know where to refer their patients, and we need to count on a clinic or clinics with experts and so on. That's the solution that people want in Quebec now. Two examples here, two people. This lady at 36, when she was 36 years old, that's when she got her diagnosis, hereditary disease, the Ehlers-Danlos syndrome. Even though she had symptoms since her childhood, again, this there's a group of diseases, for the at the tissue level. Sometimes you can screen those out at birth. In this case, with the Ehlers-Danlos syndrome, there's one type which is more frequent, but we have not identified a gene for it. It seems to be a complex etiology, but through AI with the medical depictions and the medical history with descriptions and so on, it would be possible to find out earlier and to find the diagnosis earlier. A lot of women receive their diagnosis when they are 36, 40, 50 years old. Tommy is 14 years old here. It took him 14 years. This is an example. After 14 years, he was able to benefit from research outcomes because of the sequencing technology which enabled him to receive a diagnosis. We found out that MORC2 existed, some type of gene mutation, but she's part of a group. Only a few people around the world have that. Another characterization of the disease in terms of manifestation, it's as if you would characterize a new disease. That's why it's important to use the new technology to find the right diagnosis. So our speaker for today, Mr. Nicolas Garnier, principal director in charge of advocating the rights of patients. He works for Pfizer, Rare Diseases Division. He has studied at the University Denis Diderot in Paris. He studied rare diseases. He's US-based today, but he knows Quebec well. He did his PhD in experiential medicine at McGill in Quebec and post-PhD studies in functional genetic studies at St. Justine Hospital with a researcher that we know pretty well in the field, Dr. Daniel Sinet. And he joined medical affairs for Pfizer Canada, that division, in 2015. Now, as I said, he's the main director in charge of defending patients with rare diseases. His role is to design and deliver execution on development programs which have a positive impact on the life of patients and on the rare diseases community. It's one of your projects, the Screen4Rare project. We'll hear about that. The diagnosis odyssey has to be shortened, if not eliminated altogether. And thanks to such initiatives, that will be possible one day. Thank you. Nicolas Garnier. Thank you, Gail. Good day, everyone. Welcome to this Zebra month. Thank you, Gail. Thank you to the RQMO, to the network. Thank you for inviting me today for this presentation about a project, the Screen4Rare project. And I am so honored to deliver this on behalf of Pfizer, on behalf of the European Association of Pharmaceutical Companies. I'll talk a little bit more about that during my presentation. I don't know if we can see this. Okay, as Gail was saying, with many collaborators, I work on this project. I'll tell you more about them in a few minutes. The idea is to prepare ourselves. I mean, whatever Gail told you is true as an introduction. The whole idea is to do a screening which is faster and more precise for rare disease so that we can start taking care of patients and their family. We want to shorten the path to rare disease diagnosis through genetic screening, neonatal screening, and some digital technologies can be used also. the community of rare diseases and the community of scientific researchers. Next slide, please. As I was saying, the European Association, comprised of pharmaceutical companies that I was naming, this association started working with this project as a partner. And I work with Alexandra Ferlini in collaboration with her. She's a specialist and expert from the University of Ferrara in Italy, director of the medical genetics field. Our vision, as for many other organizations, we have an initiative so that we can improve the life of patients, those with a rare disease, of course, but through specifically a faster and more precise diagnosis. Three main pillars here for our initiative, which vision is to improve the lives of RD patients with three pillar aims. As I said, this is quite complex because there are a lot of initiatives, several partners are involved. The goal is to shorten the path to rare disease diagnosis. And again, something we try to do is to compete with no other initiative. We really want to sit down with all the different partners around the same table. If we want to find synergy, develop collaborations, so as to build on what has previously been done or what is currently done. We don't want to reinvent the wheel. We don't want to overlap or create work duplication. In a sustainable way, we want to develop a new model to do neonatal genetic screening for rare disease. We want to use digital technology tools like AI and machine learning, as we say, in order to be able to do that. As I'll show you here later, the work is comprised of 6 different groups of work. At the end, they should be able to address the goals that we set for ourselves. We require the work and collaboration from all partners and workers, stakeholders concerned by this problem. Researchers, clinicians, patients, patient groups, experts, obviously, in data sciences, pharmaceutical companies, and many other partners. And at the end, decision makers. Screen4Rare is a research project, a science-based project in order to generate data. And then afterwards, we base ourselves on the data that we've generated or we will generate. And then we hope we will be able to make recommendations so as to improve the health system, the public health system, the network in different jurisdictions in which we're going to enforce our learnings. Next slide. The community of rare diseases, this is very varied. There are different communities. The majority of RD patients are RD patients since their childhood. A lot of them are still looking for a diagnosis, unfortunately, until they are adults, and then it takes them years. We wanted to have a multiple-based approach with multiple considerations, not just focusing on screening in childhood, but we want to come up with answers for the older patients on their own path, looking always for a right diagnosis. So this is the rare disease patient diagnosis odyssey. We want to map out all the other initiatives which goal is to improve the diagnosis for rare disease, to explore how we can work together, collaborate, share some results, identify where the databases are in terms of rare disease. then this could be used for developing, how could I say this? To develop and design algorithms for AI so as to identify patients in view of the electronic medical history files so as to target patients specifically. So we want to have a sustainable strategy for newborn genetic screening. We want to have digital tools, an app or online tools in collaboration with their doctors. Patients could enter a list of symptoms, and software could suggest or may suggest some possible solutions in order to get closer to a diagnosis. That's the approach to help all sorts of patients, no matter where they are, whether it's sustainable strategy, algorithm to flag patients with better known rare disease in EHR or digital clinical symptom checkers, no matter where they are on the pathway. We have to see what works better, what's acceptable or not, and we have to consider the birth, the early onset, and HCP cycling. In terms of Screen4Rare, we've done 5 clinical studies, or this is for the future. I mean, the first step will be sequencing. We'll do some genetic screening at birth for rare disease, whatever we believe is curable, that we can treat. We are still defining and improving the definitions regarding a curable or treatable disease. There are several criteria. The main criterion is that there be an approved and available treatment for patients, which eventually would be getting a diagnosis, i.e. a genetic mutation strongly linked with one of those rare diseases. We want to have 5 different clinical centers, 3 countries across Europe, Germany, Italy, and the Czech Republic. Europe, obviously, this is a project funded by the European Commission, and the Initiative for Innovative Medication in partnership with the European Association of Pharmaceutical Industries. Second clinical study linked with this, instead of using this time a panel for treatable diseases only, a panel for what we call actionable diseases. I don't know how to translate that, but this is a new concept for diseases in our rare diseases ecosystem. Beyond a treatment, we have to help patients and families. We don't know exactly how to depict this, but as Gail was saying, it's very hard to live with a disease that has not received a diagnosis. So getting a precise and fast diagnosis is so important. Inherently, this is so important. And then you can see what's feasible or not in terms of planning for the family and so on, and for the patient. Sometimes we intervene in terms of nutrition, lifestyles, physiotherapy, and so on and so on. There are many things that can be implemented possibly for some rare diseases that don't have a treatment yet. And the actionability component is comprised of some clinical research, clinical studies. This is part and parcel of possibilities here. A patient and a family can consider those, but if the patient does not have a diagnosis, then the patient has no opportunity to get involved in the clinical study. So it's important to focus on this. Thirdly, third clinical study for patients that don't have not been receiving a genetic mutation linked with a rare disease, treatable disease, or actionable disease. genome sequencing is proposed, then genome sequence screening for data that would show unaccounted for symptoms, unexplainable rather, and we do the full genome sequence then to identify then whatever can be considered, something that may not have been understood or included in the first steps. So we have early symptomatic whole genome sequence screening, and then we have to focus on the more studied, better known diseases where there is a treatment already, where there is clinical research already. Why? Because all of this is means that there's availability of data in databases, for example, or compendiums. Thanks to these compendiums or data, we can create algorithms. With AI, we can then understand things, creating links, connecting the dots between phenotypes, symptoms, and possibly the genetic disorder. Maybe not also, because it's not necessarily linked with the genetic disorder. This can be a non-genetic rare disease, but linking a phenotype with a diagnosis, simply speaking, you could do that. And then possibly you can raise a flag for the vis-a-vis the doctors for these patients and refer them to health clinics directly. So this is something that could be interesting. Fifth clinical study here, based on a better definition of the phenotype. This is phenotyping imaging. Neuromuscular considerations have to be considered here. So phenotyping imaging with multispectrum optoacoustic tomography. This is very important on this fifth component. Next slide. This is a partnership, as I said. This is a consortium, a public-private consortium, highly competitive, of course. There are a lot of pharmaceutical companies, Illumina, and so on, different experts. Illumina provides their own skills regarding sequencing solutions for genome analysis also and genetic mutation purposes. A lot of research centers from academia, many hospitals also, as you said, throughout Europe. And so it's putting all those skills together and knowledge that we can elaborate and implement such a project of such great magnitude and do it the right way. The project has started quickly. As I said, funding was received from the European Commission through the IMI process. There was an initiative for medication, innovative medication. We've worked with several partners. We've been doing that since mid 2019 in order to elaborate this project, to build it, design it, go through the several steps as pertains to the review regarding the scientific committee for the EU. We were approved and funded in October 2021. Once the goals were set, this project will last for 5 years. So we are at the very beginning of the project. We're extremely proud of it. We've been able to start it, and we're proud. Next slide. From vision to reality, this is quite complex, this table with lots of information. The goal is not to go through all of this. The goal is to show you that, as was said, we're trying to tackle the diagnosis odyssey through different perspectives, genetic sequencing, AI, and so on. This is a research project with different components The idea is to get data, generate data, analyze data to see how we can better address this issue. Maybe there's more than one way to do this. There are different ways, different implications. Many things are involved in terms of pharmacoeconomy, savings, costs for acceptance by patients, their family, and the caregivers, the hospital employees, and so on. What are the resources that can be tapped in for genetic advisors in terms of social services support and so on? All of this must be quantified, gathered, analyzed so that we can provide recommendations vis-a-vis the different decision makers in charge of health systems, hoping that obviously such a way to increase the quality of rare disease diagnosis, hoping that this would be furthered in many countries for implementation. Next slide. The communication and the fact of getting suggestions from the different partners, that's very important. What you see here is how Screen4Care works, where decisions are made, where is the work conducted. And so we've implemented different forums so as to be able to discuss and understand, listen, so that there's integration of the different knowledge coming from the different partners. We have a forum for all matters about ethical components. We've had a lot of ethical discussions. They occur and they've occurred in the past, they will occur in the future during the whole duration of the project. Again, the newborn diagnosis raises a lot of ethical issues or questions. We have also legal considerations that we have to consider regarding data. Also, we have to make sure that the data are protected, that there's privacy. We receive more data every day. Patients and family members are interested in knowing more about this. They ask, where are the data going? Who will have access to the data? This is a very important, foremost topic. We have a forum about innovation also, and one of the main goals for the forum is to understand how results and tools that will be developed within the project can be used in a sustainable way beyond 5 years, beyond the project. We have a scientific board to shed some light on approaches. And we have different people sitting on that board, but it's a tool enabling us to collaborate with different consortia and initiatives. There's another forum also, which is more varied. Experts in pharmacoeconomy, the European Commission, the European Medication or Drug Agency, and different partners, and we'll do some clinical study with them, with those partners and stakeholders, to ensure that we have different types of feedback, so that there's diversity of data, so that all the stakeholders concerned by these challenges regarding rare disease diagnosis, so that they may have a saying in this, so that they could share also their concerns and come up with their own suggestions. Obviously, we have a patient council. IRE is a partner that's an integral part in the project, So something that we're managing. We're organizing discussions between patients and reps, rare disease groups, and their representatives, so as to have an open book policy with transparency. That's what we want to do at Screen4Care, to get as much feedback as possible. Next slide. As I was saying, the voice of the patient is embedded at the heart of Screen4Care since the beginning. At the very earlier stages within the project, We wanted to make sure that patients are considered with whatever they desire. This must be embedded in the project. This is a diagnosis driven project with ethical considerations. Dialogue cannot happen without the patients. They have to lead it. There's a lot of information, of course, but this is to show you simply that we have created a solid system which has been codified so that we can get some feedback from patients at all levels, different levels, including the different levels of the project. Next slide. And I think that I don't want to repeat what has been said during the introduction. What's the impact we want to get with a faster diagnosis if we act fast? Maybe a few words. It's the multi-level impact for research that matters. We don't talk about this often. Without data, we cannot conduct research for rare diseases, and then we can't get patient diagnoses. We cannot understand phenotyping, and we cannot understand what measures are within the same clinical study. Even though we do clinical studies, we need data. That's a key point for patients. This is very important because things change, and we have to consider this for rapid and precise diagnosis. Things move, but once we get the diagnosis, we can intervene and fast, often. For the health system also, this is very important, not only for research and patients. The rare disease patient diagnosis odyssey has to consider that there are costs. It costs socially, human wise. Budgets are involved. Healthcare budgets have to be considered. So when you have an erroneous diagnosis with the wrong treatment, this costs a lot. It's not the best way to use rare resources. So that's very important for healthcare. So we can ensure better care delivery. That's very good for society and for healthcare. So we see the different impacts for research and patients. Next. There are 35 partner organizations in Screen4Rare. You see on the left-hand side, the pharmaceutical partners, biotech, biopharma partners, technology partners. In the middle, on the right-hand side, also we find the public partners, a lot of hospital centers, research centers, academic partners throughout Europe. Too many to be named all here. This is collaborative effort. We're pooling knowledge and skills in order to tackle this bold project. Now, thank you. Thanks to all of our partners that joined this initiative. There are companies, but there are academic research centers also, patient groups also. Thank you. Thank you again to RQMO. Thank you for inviting us. For my next slide, you see some resources and my information. If you have questions, go online. You can browse Screen4Rare's website and so on. It's always important to share new data. That's how you create progress. That's how we work at Screen4Rare. It's very important to support the different initiatives that are relevant. So you see my email, my contact information here, and how to get in touch with Screen4Rare or get information. Alexandra Ferdini from the University of Ferrara in Italy can also be reached via these links. Thank you.
Merci beaucoup, Monsieur Garnier, pour cette présentation. On voit que c'est un projet d'envergure.
This is a project of really great scope, great magnitude. We see collaboration at several levels. This encourages our community. We see that different partners are working currently in order to shorten the diagnosis delays for people with rare disease. first question that I'd like to share with you. Screening newborns, newborn screening. You are focused on the European situation maybe more. I don't know, but in Canada, how are things? There's no neonatal screening panel that's standardized across Canada for all provinces. So what's the situation in Europe or in the US? I think they've worked hard to create a standardized panel that most states comply with. But what's the situation in Europe? In Europe, there are a lot of discrepancies between countries. There are multiple solutions, initiatives. In Italy, there's a screening which includes beyond 40 different diseases with different metabolic criteria. Not necessarily genetic yet, but anyway, in other Europes, you have different measures in certain countries of Europe. Well, let's say you only have a handful of diseases that are screened with the neonatal screening, less than 10. That's a problem because if you want to conduct a research project, which would involve different countries, just between Germany, Italy, and the Czech Republic, you see big differences. That's why you need to start with a research project, a scientific project whereby you could set some protocols that will be reviewed by ethical committees as pertains to each and every one of the institutions. And that's a way to lead towards the creation of a standardized project involving different countries that are not standardized in their approach. A lot of work to do. In link with neonatal screening, another question. Your intent is to do more genetic screening. As for now, it's more metabolic diseases, as you said, via biochemical analyses. In conclusion, do you think that we'll be able to reach the goal so that we can use the new genetic technologies? Will we be able to do it fully or not, partly? Will be able to make the big shift. Adding one disease to a panel, proceeding disease by disease, as per disease individually, is it still adequate? Should we not go beyond that? You have your treatable and actionable diseases, so do we treat each one of the diseases separately, one by one? This is a complex question. Will we be able to reach to the full spectrum immediately? Well, it's hard because even with a positive result, with sequencing results, this is not a diagnosis per se. The diagnosis that must be determined by a doctor basing his decision or her decision on different database information. Genetic screening and metabolic screening, is that like a duel between both? Not necessarily, because one can complement the other, confirm the other. So they're not competing necessarily. They're not mutually exclusive. So this is interesting. And that's what we wanted to do. We want to use the data. We want to create a project that constitutes a great leap forward, as opposed to going through each one of the diseases one by one. No, this is bigger in spectrum. The model right now is hoping for an approved treatment, waiting for a new thing to appear, and then trying to add the new disease, which is now treatable because of the new treatment that appeared, and to use that in the neonatal diagnosis policies. But the problem with that approach is that this halts research and development because it becomes a vicious circle. If you're waiting for a treatment to be available before implementing a screening policy, while we know fairly well that without any screening, there's no epidemiological study, no genotypic, no data. It's hard to do R&D. 5% of rare diseases have a treatment today. Let's remember that. And that's one of the reasons that would explain why that is so. Breaking the vicious circle would mean, no, let's do the contrary. Let's improve the diagnosis in order to create solutions for families and patients. We need to unblock research, R&D also, so that more treatments will be developed, so that more are approved. It's a change of paradigm, a shift we hope to be able to create. With the advent of sequencing technologies, obviously there's a unique opportunity. This unique opportunity is creating economies of scale. On a panel today, whether you have 100, 200, or 2,000 genes, cost-wise, it doesn't change anything or much. So we understand from the get-go that this constitutes a great opportunity. To finish on that, last question, we would have to think now about maybe, well, we could think about creating some other times for sequencing, using new technologies, thinking about new opportunities for that. Before, I mean, there are gene panels available so that a couple can, or a woman or a couple, they want to have a kid or she wants to have a kid, they can be tested before intercourse. They would determine if they have thousands of genetic diseases, potential. So this is available only in a certain way. To know ahead of time, this decreases the level of anxiety. This is information that's very useful for a couple, and then they can decide to do whatever they want before the intercourse. This is not prevention necessarily, quote unquote, in the sense that we must think of considering a neonatal diagnosis necessarily, but we can get prepared to the birth of a certain child in a certain way. And so at the RQMO, we're not really thinking about, people think that we're not really talking about this. There are frequent diseases for certain ethnic populations, but things are really badly enforced. The information is not used well in our network. There are new studies about economic advantages for neonatology. So for a baby that gets there, it means that there's a problem. We can quickly intervene. We have the clinical information, and with genomic sequencing and so on, we can, with sequencing, I mean, this could be a first way to enforce or implement things. This could be used in all countries because this is available. There are costs, of course, but we can proceed through some elimination, as we say, considering the different panels could be more costly, right? So this is my last question, and then we will have some questions from the audience. Today, there are more registries, patient-driven registries, patient-initiated registries, created and managed by patients' associations. In the States, the Genetic Alliance, for example, there are other ones that appeared. The principle being that why wait after researchers and clinicians before creating a registry which will be costly, it may not last long, it may not be useful regarding patients' questions. There are more registries like that. We do promote some since fall. We've promoted some with patients and their families and their helpers. we counted 150 such registries where patients manage themselves the data. They enter their data. It's well designed. Platforms have been developed with the NIH, the FDA. This is safe. There's security. So the patients decide what information they provide or not, what they make available for researchers. And these are anonymous data. And so I wonder, is that something you are considering? Self-entered data, self-reported data by patients. Are you considering this? Good question. And in terms of rare diseases in that field, the research agenda and initiatives are carried out by organizations, patients' organizations. We expect a lot of databases that we've identified for our preliminary work, for the mapping of initiatives, for the mapping for databases. We expect them to be organized registries implemented by patients' organizations with possibly self-reported data, whereby patients enter their own data. All the databases that we will identify that could be interesting for Screen4Rare, it will be assessed in the standardized way from different points of view for different usages. And what about consent? Adequate consent from patients. This must be there so that the data can be used for research and for Screen4Rare. For example, we would need to know where the data are, if we want to find them, and so on. I can't give you a straight answer, a yes or no. This is a reality and we're preparing for it. All the database information will be used, reported, and used if possible. So if you have any questions, members of the audience, you can do so. Luc Charpentier, I don't know if you see him. He joined us. He's our director, and he's considering the questions here. On the chat here, we have a question. I think somebody was asking a question. This is very interesting. Your project is very interesting. She says, can we have access to that in Quebec? I'm not sure I understand well here. Maybe she needs to clarify, but anyway, for now, there's no recruitment of patients for the first phases. Anyway, I don't know what you can tell her. For now, this is just a project which focuses on Europe. It's led by the European Association of Pharmaceutical Companies and the European Commission. Then, for our mapping work regarding possible partners, we are currently exploring possible collaborators. I don't know how to call them. Yes, let's call them collaborators from a comprehensive point of view. And of course, we're looking at what's being done in Canada and in North America. And I'd like to mention something, by the way. We have a Canadian researcher that's part of our scientific board. The link has been created. There's a relationship. And we know there's great research on genetic data for rare diseases in Quebec. And generally speaking, in Canada, the research is great. There may not be a screening center where screenings would be monitored, maybe not, but there are intellectual discussions, sharings, scientific sharings where people share knowledge and skills. Now, in our next sessions, for our next Zebra webinars, we'll have an initiative here in Quebec for exomic sequencing. the Canadian project from C to C. Kim, anyway, in Canada, they've been solving through sequencing some genetic diseases. Another question: does screening exist for adults? Genetic screening, is this done for adults? As a genetic advisor, I'll answer the question: yes. In Quebec, in Canada, but Ontario is making more progress. But sequencing, exomic sequencing, this is more for research now. In Ontario, we're considering something else for clinics, but we're not there yet. We're doing some panels. And for pediatrics, yes. For children, yes. But some adults may be part of research projects. For example, for genetic sequencing, sometimes adults can be part of that. For certain cases, amyloidosis, for example, there are some diseases that are not genetic. In certain cases, yes, there are. There's a treatment in one case for a specific gene. There's a treatment right now. So in certain cases, anyway, that's it for now. We don't have any other questions. Thank you for this very interesting presentation. It's very important for us. People in Quebec have to know, must know what's happening internationally. That's very important for us. They have to know that things are making progress, things are being furthered. We have a few initiatives in Canada, but we don't have all the network, the collaboration with the policy strategy in Canada. We don't have that yet. For rare diseases, there are initiatives internationally, but for us to learn from international initiatives, this is of paramount importance. So thank you so much for coming. Thank you for your great presentation. I'd like to say also that maybe you'll be interested in this. You said that you want to know more about other initiatives. Our next Zebra seminar will be 2 doctors, 1 researcher from France will be involved then. This is on February the 10th. Anita Berger, doctor, and Nicolas Garnier, professor. This is an initiative from France and Quebec, joint initiative with researchers from the Paris University, Université de Paris, and the University of Sherbrooke. And this is Le Réseau Ensemble, literally the Together Network. We work with them at the RQMO. This is a learning system for rare diseases. Learning is a new term, a learning entity, a learning organization. It's a fashionable term. You've talked about those considerations without talking about the term, learning. It means you can use the data from medical history, from medical folders, from the network and so on, the health network, in order to better diagnose patients with rare diseases so that we can better take care of them. With Jean-François Litier, internal medicine here at the CHU from Sherbrooke. They're working on that. There's also something about ethical components, legal components, and the differences between France and Quebec at that level that we are foreseeing also. We'll deal with that. So because we'll have a presentation on that, this will be held on February the 10th for our Zebra conferences, Réseau Ensemble, and also Dr. Warehouse and AI initiative. Also, maybe you've heard about it. And we'll have 2 other webinars, Zebra webinars on exomic sequencing, an initiative from Quebec, and the C2C Canadian initiative with a Zebra webinar from the US Genetic Alliance Association with Ms. Sharon Terry. By the way, she's just launched an initiative whereby thousands of people can have access to sequencing, the new technology of sequencing, in order to get a diagnosis. We're looking forward to it. We want to learn more about it. And the last Zebra webinar, Franck Béraud from Montreal will come in and tell us about a strategic plan that was proposed by the life sciences sector here in collaboration with us, the RQMO, and also associations, rare disease patient associations. On February 19th, we have a quiz, a competition for medicine students with an award, $2,000, and our educational day on February the 26th to talk more about how to support one another during the long time that it takes before getting a diagnosis through the Rare Disease Patient Diagnosis Odyssey. Thank you so much. Thank you to our listeners, and thank you, and see you soon. And join us at our next Zebra webinar. Thank you.